Good evening, everyone, and welcome to the webinar on Role of NGS in Solid Tumors. It gives me great pleasure to invite our first speaker, Dr. Vamshi Krishna Thamtam, Head Genomics and Clinical Cytogenomics, Delhi. Over to you, sir.
Very good evening. Thank you for your kind introduction. So can you see my screen?
Yes, sir.
Okay, wonderful. Should I start?
Yes, sir.
Okay, great. So I'm going to speak about practical aspects of next generation sequencing working and analysis and what the oncologist should be understanding. The first slide talks about molecular pathology. These are the various platforms that we use for our cancer patients. Each of these different platforms has different advantages and also limitations. And as we truly understand that we are in the era of next generation sequencing. Next generation sequencing is also known as massively parallel sequencing. There are various applications in clinical diagnostics that we use these days. Most foremost and primary would be your cancer genomics. Inherited disorders, wherein we understand that there are exome sequencing, we look at rare disorders. Infectious diseases, we're trying to look at the microbiome, of these transplant patients. The transplant and HLA, immunology also uses next generation sequencing, as well as when you're looking at in the field of reproductive medicine, in the field of in the form of non-invasive prenatal screening, we also use next generation sequencing, NGS. So talking about NGS, we'll have to first give regards to Frederick Sanger in the year 1977, who was the first to kind of devise this chain termination method of sequencing, wherein a dideoxynucleotide was incorporated and the chain gets terminated. So here, if we look at a DNA strand, we denature the DNA strand and we look at which target or gene of interest that we would want to amplify or that we want to look at. We make primers for it, the forward and the reverse. It's always the bidirectional sort of Sanger sequencing, which needs to be believed, which needs to be trusted. 4 nucleotides that our genome is made of, A, T, G, and C. And these primers, they bind to the region of interest and they amplify them. And once these chains are amplified, they kind of can be looked at as to which gene or which target region we've amplified. During this amplification, if a dideoxynucleotide is incorporated, the chain gets terminated there. These chains, wherever the dideoxy, say, an ATP, a dideoxy GTP is being incorporated, and the chains terminate at various levels of nucleotide incorporation. These chains are run through electrophoresis, and we understand that we see a sequence. So this sequence of the gene target of interest is laid down against a reference genome, the human reference genome, and we see if there is a change. Here, as you can see, there is a homozygous change from G, which is supposed to be there in the reference genome, and in the patient, we have an A. So it's a homozygous G to A change in the specific gene. Fast forward from your first generation Sanger sequencing to the next generation sequencing. So next generation sequencing, as I mentioned earlier, it's also called as the massively parallel sequencing. Why? Because in parallel, there are lots of Sanger sequencing which is going on. It's not just one gene or target region of interest, multiple genes, multiple regions of interest, multiple targets we are looking at similar at a singular time point. And this is being possible because there are multiple primers, multiple regions that we are looking at. There are 2 common, rather popular technologies in clinical diagnostics: the ion torrent, also called as the Thermo Fisher, and the Illumina. So these use different chemistries, and based on these chemistries, there are multiple regions of these targets which are generated as short reads, and these short reads are laid down against the human reference genome, and we see what is the difference between the reference genome and in the patient's tumor. This is the NGS workflow. Once the sample is collected, we extract the DNA, we extract the nucleic acid. When we are extracting the nucleic acid, we kind of have to look at what quality of the nucleic acid that we've extracted. Is it good? Is it bad? So for which we use the spectrophotometer as well as the fluoroscopy. So these kind of tell you what is the amount of nucleic acid present in the extracted elute that you have, as compared to proteins, as compared to salts, or as compared to any other impurities that you have, that the chemicals, the reagents that you use during the extraction. So that purity is extremely important, because that goes into your next level, which is a library preparation. Our library has many books akin to a massively parallel sequencing, wherein we're looking at multiple regions of regions of interest. So one gene is one book, and multiple genes are multiple books. So a library has many books, and that's the reason why we call it as a library preparation. We're looking at massively different regions of interest in a specific tumor. So once the library preparation is done, we would also want to look at the quality control of the library preparation of the library which has been prepared, for which again we use the fluoroscopy, which is also called as the qubit. And once we are happy with the QC after nucleic acid extraction, after the library preparation, we go in for sequencing. And this sequencing is where you are looking at the ATGCs of the entire, the tumor genome, and we get these sequences. This is the bioinformatics part from the fourth step onwards, and we try and look at the good quality scores or the bad quality scores, and we try to align them against the reference genome. So once we align against the reference human genome, we understand that the aligned reads have a specific nucleotide change or any specific nucleotides which are deleted. So this is called as the variant calling. So we've called out a variant by saying that, yes, there is a missense variant, another nucleotide which is incorporated, or there is a deletion of these specific nucleotides which were supposed to be there in this specific segment. And that's what we do the variant calling. What happens with variant annotation is that there is a G to A change in the exon 15 of the BRAF. But how do I annotate it? I would call it as the BRAF V600E, and that's where it becomes an actionable or a noticeable change in that particular gene for that specific tumor. If you look at this, cartoon, it just purely gives you the way the previous slide also spoke about the workflow of the NGS. And in the variant interpretation, what happens in the bioinformatics analysis is that if a variant is found and that variant is not present in the popular database, in the popular onco databases, in the form of CBio portal, in the form of Jackson Laboratory, in the form of CleanVar, you look at the population frequency. If one person, so a difference between polymorphism and a mutation is 1%. 1% of the population has a specific variation, a specific nucleotide change, then I would call it as a polymorphism because it's present in 1% of the population. If it's present in less than 1%, then I would want to call it as a mutation and try to give importance to that specific change. When I'm looking at literature review, has this variation been reported earlier? Has this variation been targeted earlier? And what is the follow-up of those patients? When you're looking at the in silico predictions, what happens with this variation? Does it change the conformation? Does it change any a part of the protein which is being formed by that specific gene? So that is the in silico predictions. And when you look at co-segregation analysis, it's always important that the germline mutations look at both the parental, both the paternal as well as the maternal, to understand whether it is a de novo variant or has it been carried down through into the families. So this is what happens in the bioinformatics part, wherein we try to look at the variant interpretation and we annotate that variant, which goes out into the report. Now, what are the various changes which can be seen, in a specific gene? If you're looking at here, there is a gain of a specific gene. There is a loss of any specific gene. So this is called as the copy number alteration, the copy number loss, or a copy number gain. We look at copy number gain in, say, HER2. We look at copy number loss, say, in a TP53 or a 17p. If you're looking at indels, there can be an insertion or deletion in the genes, which is looked at, which looks like this. A point mutation can be very well noted over here. If it's a BRAF gene, is it fusing with any other gene? Is there a translocation, and is there a gene fusion? So the BRAF, KI AA1549, which you usually you look at in a midline gliomas, that fusion can also be seen. So this visualization of the reads which you have generated by next generation sequencing is called as the IGV, or the integrated genome viewer. So once you look at an integrated genome viewer, you understand if there is a point mutation, if there is a deletion of any of these nucleotides, if there's any copy number loss or gain, or if there's any fusion between these two genes. So this is called as the IGV, and it gives you an allele level change. There are certain mutational signatures which are quite popular in tumors. If you look here, there is C to A, C to G. There are multiple sort of transitions and transversions, wherein here it is more of C to T in a background of certain changes. Here it's purely C to T. So these signatures are sort of common. Rather, we are relating these signatures to specific tumors. When we talk about allele configuration, one, we have the chromosome from the mother and one from the father. So if one of them is a mutant allele, it's a heterozygous variant. There can be focal amplifications of this particular gene, say HER2 amplification. There can be genomic losses in the form of whether if there is a loss of the normal TP53 and normal or the wild type TP53, and the mutated TP53 is now dominant. There can be copy neutral LOH, wherein the wild type is totally lost and you have both the copies of the mutant allele. There can be a whole genome duplication, the polyploidy, which is usually seen in a solid tumor. And there are other forms of imbalances as well. We're looking at structural variants. These are the translocations. So if in a reference genome, the gene 1 and 2 are together, there can be deletion of the gene, of one gene or two genes. There can be inversion of the genes, and so it might form an inversion 16. A translocation can be formed, wherein a gene or a region from another chromosome comes and fits into this particular genome in a 3 to 5 in 3' to 5' position. There can be an insertion of a gene. There can be other complex structural variants which can be seen on a higher scale, on a sort of lower resolution, like karyotyping or a chromosomal microarray. When you look at conventional testing, we understand that we need to form a diagnosis first. Then we kind of type it histologically or histomorphologically, then try to look at the IHC, if we are able to put it up into a non-small cell lung carcinoma, into an adeno or a squamous. This was the traditional way of doing it. And then we used to go in for a reflex testing in the form of EGFR, and then if it comes negative, then AL, cross, and so on and so forth. And then a small panel, and we just look at a small panel to see if there's any targeted therapy available, and if the targets are not met, then we go in for a PDL1, which is IHC2. So this tissue becomes a big issue when you're looking at the conventional testing. It's very important to understand once the biopsy is done, two variables. One is cold ischemia time, and two is the fixation time. The cold ischemia time, as you can gradually see, and this is 1 hour, how the tissue looks like. This is 2 hours. This is 1 hour. 1 hour after the biopsy is done and is put into the formalin. This is 2 hours, after which it is put into the formalin. 3 hours, 4 hours. So if you see the positivity for IHC for this particular, ERBB2 or 2, the positivity wanes, and once the cold ischemia time is more, once we've taken longer time for the tissue from normal saline to put it into the formalin, then it might actually, we actually might lose out on those epitopes. We might lose out on those proteins which can be the targets. The same with fixation time, if you're looking at 12 hours fixation and 24 hours fixation. So an optimal fixation is important. You cannot actually overly fixate, not more than 36 hours, not more than 24 to 36 hours is what we usually recommend. I just have a couple of cases from which I just want to make you understand the terminology for what looks like. This was a high-grade serous ovarian carcinoma. So it's a comprehensive genomic report. Why is it comprehensive? Because it looks at both RNA as well as DNA. In the RNA fusions were not detected, but what about the DNA? From the DNA, we are looking at a single nucleotide variant. We're looking at indels. We're looking at copy number variations. We're also looking at the MSI status of this particular tumor, the tumor mutation burden, as well as the HRD score. So these are the various things which would come in when we're calling it as a comprehensive, genomic profiling of that specific tumor type. This is another case wherein we're looking at a medullary carcinoma of thyroid, and we got a RET mutation in exon 9. So this it talks about relevant therapies as well, which are FDA approved, which are included in the report. A metastatic carcinoma of ovary is the third case here. We kind of found FGFR1 copy number gain, And this copy number gain was actually sort of replicated when we did a cross verification on another platform. So trying to truly understand that yes, the FGFR1 is truly sort of amplified in this particular tumor. So from formalin fixed paraffin embedded tissue for which we use the next generation sequencing. The next generation sequencing is also useful to look at liquid biopsy. The CAP, IASLC, and AMP usually regulate the industry's testing guidelines. We do not have testing guidelines at the moment for liquid biopsy. So it has to be lab-based, lab-specific. The ASCO and the NCCN obviously, endorse these treatment as well as the testing guidelines. So this is one of the most popular sort of cancer that I took at that I want to look at, the lung cancer, wherein if the cell-free DNA testing or the circulating tumor DNA testing by NGS is not as an alternative to histological tissue diagnosis. Histological tissue diagnosis, if it's possible, it's always better. Because there are certain negativity that we see on the plasma, rather on the cell-free DNA testing, nearly about 30%. So when the patient is unfit for an additional tissue testing in a newly diagnosed patient, and when there is an insufficient material for molecular analysis, obviously we'll have to fall back on the ctDNA. If the patient is on progression and the original biopsy was negative for any of these targeted mutations, then obviously we can go in for a liquid biopsy, because in a liquid biopsy, the tumor heterogeneity is much captured as opposed to a single site of biopsy in a tumor that we are trying to biopsy. Obviously, the liquid biopsy would have a reduced turnaround time because you do not have any fixation. You do not have to fix the tissue and then subject it to next generation sequencing. You can straight away use the plasma and then separate out the cell-free DNA, the circulating tumor DNA, and go ahead with the testing. And obviously, there's an increased yield of targetable alterations because the tumor heterogeneity is much better captured on the liquid biopsy. There are studies which obviously talk about concordance between liquid biopsy and FFP-based tissues as well, and they found good biomarkers and good value to their patients. But as I mentioned earlier, there are no testing guidelines available as such because performance characteristics of each lab are different. We are good in doing the cell-free DNA. 30% of the times when you have a falsely negative, when you have a no pathogenic variation detected at all, on a liquid biopsy, we obviously have to fall back on the tumor biopsy or the histological biopsy. So here, one of the cases that I'm mentioning over here, it's a lung cancer. The patient is positive for the common mutation, which is L858R. It's nearly seen about 32% allelic burden in the liquid biopsy in the blood. Along with the L858R, we are catching a good variant allele frequency of the another mutation in EGFR gene, of the KDM5A gene, and all the other different genes that we're looking at. All this comes up in liquid biopsy and not in FFP biopsy because. Not in the FFP tissue because the tumor heterogeneity is very well captured in the liquid biopsy. As mentioned earlier, this is the era of precision oncology where we practice evidence-based medicine. So it's not just the genomics or the transcriptomics. We have to look at a comprehensive tumor profiling by looking at also the proteomics as well as the metabolomics. So that's the future that we're going through. And I think a tumor profiling on the next generation sequencing is going to go into the next generation sequencing, which is your long read sequencing, by which we actually have looked at very complex regions of the genome, including the Y chromosome, and now the entire human genome is complete. And for any tumor to be adequately typed, there should be a driver, and the driver should always be the therapy or a management which is available. So we are going towards a comprehensive not just the genomics and the transcriptomics, but also the proteomics and the metabolomics in the future. Having said that, that's my last slide, and thank you for your patient listening.
Thank you so much, sir. I would now like to invite our next speaker, Dr. Ketan, consultant medical oncologist from Fortis Hospital, Mohali. Over to you, sir.
Thank you, ma'am. Thank you, Dr. Lal Pats. Thank you, Dr. Vamshi Krishna, for this opportunity to discuss the practical aspects of NGS. Dr. Vamshi, am I audible?
Yes, yes, you are.
Yes.
Thank you.
I would like to know from you, can I ask a question regarding VAF, variant allele frequency?
Yes, please. Yes, please.
So please enlighten us something about the VAF, the importance of VAF, and how do we take a decision based on the percentage numerical value of VAF?
So a variant allele frequency basically talks to you about what is the tumor, what is the variation, what is the percentage of that particular variant present in a tumor. Let's take an example of a BRAF V600E. So once an FFP tissue comes in to the lab for testing, we have to check it for the tumor percentage. How much of the tissue which is present in that FFP block actually has the tumor. So if I'm getting a 30% tumor or a 40% tumor, and if I am able to correlate with a variant allele frequency that I'm getting on the NGS reporting as 30 or 40%, I can understand that that the tumor has that BRAF a variant. But when it comes to when the tumor is beyond 50%, and if I'm getting a variant allele frequency of beyond 50%, please understand that because we have tested the FFPE specimen, we would not be able to differentiate between whether the BRAF V600E or any variant is present only in the tumor, or is it also present in cells which are beyond the tumor, which is a normal tissue as well. So this FFPE based NGS variant allele frequency does not give you the differentiation between whether it is a somatic variant or a germline variant. Anything beyond 50% of the variant allele frequency is something which we might kind of want to probe in to see if it is a germline variant.
Is there any lower cutoff to make to say that it is actually significant?
So most NGS tests in the world basically put up a variant allele frequency LOD as 5%. Now, why is it 5%, 5? Because if I am subjecting an FFP block which has 10% tumor cellularity, so if I put my cutoff of tumor percentage as 10%, then I'm getting a variant allele frequency of 5%, which is present in a heterozygous state. That mutation is present in a heterozygous state. So I will put up my LOD as 5%. So 5% is what is your cutoff for it to be actionable. Below 5%, you obviously have to look at whether the patient is a follow-up patient or has a chip mutation. So there are many of these clonal hematopoietic, hematopoiesis of indeterminate potential clones which try and keep up with the hematopoiesis, like the DNMT3A, the TET2, ASXL1, JAK2, and so on and so forth. So those are the ones which you have as a subclonal population, less than 5. So those are not the actionable ones. The beyond the 5% is what is your actionable, or rather your true tumor sort of variant allele frequency for that particular variant.
Got it, sir. Thank you so much for clearing this doubt. So, thank you for displaying my slides. Next, please. So we'll be discussing the practical aspects of applying the NGS report in the context of the most common malignancy, that is CA lung, non-small cell type, where we have a lot of data, a lot of database regarding the mutations and the maximum number of target therapies that are emerging for each specific target. So this is a busy slide where you can see the various mutations in the lung cancer that are being shown above in the pie diagram, starting from EGFR, L, CROS1 to the newly discovered ones like the NTR, KRAT, MET, KRAS, and others. And on the left-hand side, you can see the importance of PDL1, tumor mutation burden, and MSI testing. And accordingly, on the lower half of the slide, you can see how the therapies have evolved, starting from 2003 when gefitinib became available, and thereafter how they have evolved, and we have therapies for all these targets. Next, please. So in 2003, in the beginning years, the guidelines recommended just EGFR and ALK fusions. Thereafter, they evolved into addition of various other findings like ROS1 gene fusion in 2018. Then VRAF tested was included. Now the most recent guidelines have a list of roughly 12 mutations which are listed here. And the current testing modalities assay these 10 to 12 targets in quite varied methodologies, whether it is PCR, FISH test, IHC, and now latest we have the NGS. And here we'll be discussing the various NGS reports of the patients that we have treated and the findings that were seen and the various therapeutic targets that were applied into clinical decision making. Next, please. So the current NCCN guidelines have this list of targets, the EGFR, which we target with various drugs, starting from Geftin to the latest, that is osimertinib. Then the 20 insertion mutation, which is a quite resistant one to these oral TKIs, and for which now is newly available is amivantamab. Then the KRAS, and these drugs are not yet available in India for KRAS. ALK, ROS1, we all know. BRAF, we all know started from thyroid and melanoma and colon. NTRK, the drug is also made available recently. That is larotrectinib, quite effective. Then MET exon 4 skipping mutation, RET arrangement, and HER2. HER2 we know is derived from the growth driver of the CA breast, where we have trastuzumab and the various congeners of trastuzumab that we use in clinical practice. That is now also found to be useful in HER2 positive CA lung. Next, please. So coming to the first case, we have a 40-year-old female, a non-smoker with chest pain and breathlessness. Imaging showed pleural effusion and a right-sided lung mass with bilateral lung mets. The cytology for pleural effusion was positive for malignant cells. Biopsy showed adenocarcinoma. Next, please. So a comprehensive NGS was done, including PDL1, TMB, MSI as well. The question is whether you would do a comprehensive panel or a limited lung panel or just limited to EGFR, ALK, ROS, or would you do a simultaneous liquid and solid or any other? So nowadays we have now switched to moving to lung panel, complete lung panel by NGS, as now even medicines can be available for some patients, even if they are not available in India. Plus we also do PDL1 because we know that PDL1 and PD1 inhibitors are very effective once the value is more than 50%, even monotherapy is effective. And once the value is positive, then combined with chemo, it gives wonderful results in survival benefit. So practically in our practice, we use comprehensive NGS panel with PDL1 testing. And if we do a solid, we prefer a solid, as Dr. Vamshi also said. And if we add a liquid biopsy, the yield increases. Next, please. So what type of therapy we would employ? So in our practice, we don't give any empirical targeted therapy till we identify the target. In case the patient is having an emergency of symptoms like recurrent pleural effusion, severe bone pain due to metastasis, or impending liver dysfunction, then we resort for chemo. Otherwise, if we can wait, we wait for the results of the biomarkers. Next, please. So we don't start upfront IUs when we do not know the EGFR mutation status. That's the reason is that we'll see in the next slide. Next, please. So we have a lot of data to show that if there is an EGFR mutation and we are using PDL1 inhibitors, there is a lot of lung toxicity and immune-related events. And this was particularly specific to osimertinib in this study, where PDL blockade followed by OC. When we came to know, we started PDL1 blockade, but once the EGFR were doing positive, we switched to OC. That's not the right step. It is better to have the biomarker reports first and then decide the targeted therapy. Either you can wait or you can start chemo upfront. We have reports where these agents are less effective once there is EGFR or targeted mutation present. Next, please. So again, this in the paper showing the EGFR associated TK associated toxicity in patients who have been treated with IOs. Next, please. So this is a paper which shows that OC can be combined with selective other agents, which has been found to be safe for the patients. So it's all made on a case basis. You decide what will be the sequence of targeted therapies in lung cancer. Next, please. So yeah, we start the patient on chemo, as I said, and in case the PDL1 is 0%, then we discourage the use of IOs, because as the PDL1 value rises, the response rate and the survival benefit of IOs increases. Next, please. So this is a 40-year-old female non-smoker. So usually we expect it to be EGFR or driver mutation positive. So if the report is negative, we can add a liquid NGS, which will add to the yield. Or we can, in case we are in doubt, then we can repeat a tissue biopsy if it is easily possible. Next, please. So a study by Agarwal et al. Showed that plasma cell-free DNA testing added to approximately 20.5% of patients with tissue alone approach, which increased to 35.8 when both of them were combined. So another study comparing a tissue versus first versus cfDNA approach to the evaluation of recommended biomarkers reported detection rate of 68% versus 87% and 33 versus 13% respectively. So the incremental addition in the detection of mutations with these methodology. So liquid biopsy has been discussed by Dr. Krishna in detail. Next, please. So it provides a convenient and promising option for molecular profiling in patients with an SCLC. Usefulness is limited to cases where a targeted mutation is detected, whereas a negative result is less informative and warrants tissue-based biopsy and testing. Next, please. So the science is evolving, rapidly evolving, and there are several gaps in the biomarker testing, but that gap is getting closed with time and evolving technologies. Next, please. So case number 2, we have a 59-year-old gentleman evaluated for backache, 4 months duration. Eventually, he was found to have a mass on PET CT that was 4 centimeters inside with mediastinal lymph nodes and 5 bone mets. He was having symptoms related to the bone pain, and the CT guided biopsy showed adenocarcinoma. The PDL1 by DACO methodology was 80% TPS, 80% combined positive score CPS. NGS showed STK11 mutation. So this is the catch. The TMB was low, that is 4 mutations per megabase. MSI was not high. Next, please. So CA lung adeno CA, high PDL1 with STK11. So he's not keen for chemotherapy, as we know that had there been no STK11, so PDL1 more than 50% with driver mutations negative, you can use Pembro straight away in single agent and you expect great response. So what will we offer to the patient here? Next, please. So the point to highlight is that with this mutation, the tumor is a cold one, it is refractory to immunotherapy. So in this specific mutation, the use of anti-PDL1 agents is not recommended because we don't expect great response. Next, please. So regarding the predictive effects of STK11, there are mixed results across studies. Some studies indicate poor response, but other studies note a prognostic but not a predictive effect. So independent of PL1, there may or may not be impact, but as of now, today, when this particular mutation is present, we prefer chemotherapy rather than anti-PDL1 therapies. Next, please. So this slide shows that with these certain mutations on the right side, it is better not to employ these costly therapies, that is pembrolizumab, nivolumab, etc. Once these driver mutations are present, it is better to use the specific target, or if that target is not available, then prefer to use chemotherapy. Next, please. So at present, do we modify our treatment strategy? Yeah. So we discuss such mutations with our pathologists and in the molecular tumor board and ask them their importance, and with team discussion, we proceed with either the target therapy or the chemo or immuno. We take a decision with the help of our molecular pathologists. Next, please. So these are the KRAS mutations. So this study, Checkmate 057, that confirmed that patients with KRAS mutations benefited more than nivolumab than those without KRAS mutations. As we can see in all the subgroups, it was better than the chemotherapy in the KRAS mutations. 15 to 20% of patients, particularly smokers with lung adenocarcinoma, will have KRAS mutations, and they are responsible for tumor formation, proliferation, migration, diffusion, and angiogenesis. Another study also showed that atezolizumab is also more effective in patients with these mutations compared with wild-type KRAS. So we can see in this red box that the response depends whether the KRAS mutation is positive, much higher response, whereas the dot is on the baseline when the KRAS was wild type. Next, please. Another case of 40-year-old female non-smoker with chest pain and breathlessness, pleural effusion cytology positive for malignant cells, 5 centimeter mass, and bilateral lung nodules, biopsy adenocarcinoma. Next, please. So the biomarker analysis showed ERBB2 mutation with a variant allele frequency of 26%. The report reported that the patient will be sensitive to ERBB2 inhibitors. It was an oncogenic mutation. Dr. Vamshi, any comments on these findings? If you can make us wiser on this. Next, please.
Yeah, sorry, can I get back to that?
Yeah. Previous slide, please. So this was a female non-smoker with adenocarcinoma lung, and this is the NGS report finding.
So this was done on the FFP block, and when you're looking at a 26% variant allele frequency, I would obviously want to look at what was the tumor cellularity in that. So it usually sort of gets to that level only, and obviously it is oncogenic. It's one of those the common mutations along with L858. It's the del19.
Yes, so we'll target this mutation. That is your advice. Next, please. So this HER2 exon insertion with the PDL1 high, that is 26%. So there is no clinical trial and patient is affording for IU. So what will be our therapy of choice? So here we can choose to target it with anti-HER2 therapy, which we'll see on the next slide. Next, please. So the data from clinical studies that we have is that pan-HER inhibitors, dacomitinib, neratinib, or afatinib, they will have modest response rates of 10 to 20%. We don't have the selective HER2 exon target therapies available in India, that is the positinib or pyrotinib. They might be available in the US in clinical trial. The HER2 mutation that we target in breast cancer, obviously we can target it with trastuzumab, and the response rates have been not much, practically negative. So no, the drugs that have worked maximum is TDM1 in this setting, or the trastuzumab deruxtecan that will be available next month onwards in India as well, that is Enhertu. So basically the point that I want to bring home is that once we have such a report, we should have a team discussion with especially our molecular pathologists, look at the clinical condition, the affordability, the availability of clinical trials, and whether there is robust data to target it, or whether to use the classical therapies, that is the chemo or the IOs if the PD-L1 is high. Next, please. So this already discussed that we should not use, once the target mutation is available, we should target that mutation, whether it is non-EGFR, non-ALK. So we should use these costly agents which have significant toxicity. Once we are sure that there are no other targets that are targetable, then we have the better results in clinical practice. So I think this discussion will suffice for the current session, because there are so many cases and the discussions are endless. So any comments from you, sir? Vamshi, sir?
No, I think it's wonderful. I believe this is a prototype. The lung cancer is a prototype on the solid tumors as against your CML, which it started off with Gleevec back in 2000. Lung is something which we've had so many things to do for the patients. It was initially just 6 months, 8 months, and now you see 5 years, more than that. Especially ALK positive, those people really do well. I think we're doing a wonderful job. Congrats to you and the entire Medon team, everywhere.
Thank you. Yeah, ALK inhibition has as high response rate as 80%. 80% response rates in clinical trials. Yeah, things are really improving fast. So in future, sir, we will seek your guidance, your advice regarding the reports, and
I would love to help. I would love to talk about whatever is possible, for a holistic, as you rightly mentioned, the tumor boards, be it the molecular tumor boards, be it your histo, be it your counseling sessions. I believe the core of any patient well-being is always a counseling session. He needs to understand not only what's happening with him, his finances, his family. He also needs to understand what's happening to the sample that he gave in the lab. He needs to understand. He needs to have the confidence not only in the doctor, you sitting in front, but also the lab which is giving out the report on the basis of which he's getting those expensive treatments, or he's getting those good responses that he's getting. So I think together, we can definitely sort of do not only for just the lung cancer, but also the ovarian, prostate, breast, all of these which have really good targeted therapies available. FDA has been really fast. I think the pan or the tumor agnostic therapies where we are looking at into the future, not just the TMB, MSI, NTRK, RET, not the BRAF V600E, just these, but I think beyond that also we should be able to help out more patients in that. That's my opinion.
Yes, sir. Ultimately, it's a team approach in sync with you. We are also learning to apply these NGS reports and further other tests. And I think things will get much better for patients in the future. And we wish them great luck. Thank you.
I echo with your emotion.
Thank you, Dr. Lal. Thank you.
Thank you.